I would like to thank Dr. Bertelli for this recognition and this wonderful prize. My paper is related to some activities undertaken by our association. The association was founded in 2002 with the aim to fill some professional gaps in the field of visual rehabilitation in cases of retinal dystrophies, especially for what concerns macular degeneration and retinitis pigmentosa. In our logo, we want to represent the damages that are created with macular degeneration, that with the loss of central vision and as difficult to recognizing faces, reading, etc. And what's happened with the retinitis pigmentosa, where is the peripheral part of the retina to deteriorate, giving problems during the orientation. Thus, in the yellow windows are represented the progressive deterioration of the macula, while in the blue one is represented the opposite problem. The visual rehabilitation in Italy, although in discussion for a long time, is still very young, and coordination between the centers throughout the area is quite complicated. The Lombardy region has attempted to redress this problem by setting up a working group for the implementation of the guidelines on aid to the low vision therapists, where the Association Retinitis non-profit organization has participated with Dr. Chiara Pierotet and me. Once the guidelines has been written, seem to us be more appropriate work on the experiment and develop tools and strategy designed to activities to be performed, rather than taking into consideration only the tools available at that time and borrowed from the ophthalmological practice. Certainly useful for the diagnosis and prognosis, but not so important for a center of vision who normally welcomes patients already assessed clinically and with expectation addressed mainly recover toward the autonomy of the normal activities of the everyday life. Taking care of patients with low vision is definitely a very important moment. To offering the chance to discover what is a residual vision can be useful for an effective rehabilitation program was our first goal. Thus, we evaluated the possibility of creating an optotype chart for a functional evaluation, both in terms of visual acuity and contrast sensitivity. At the end, our choice was a chart that presents a series of optotypes with centesimal scanning that reproduce the effects resulting from the use of a magnification system. More the image is large, smaller is the area of vision, and assess the different qualities of light to indicate what is the most appropriate. During our evaluation, we very often have found that when the patient becomes impaired in the adulthood, using a visual acuity less than which one we found during visual functional testing. Our conclusion was that the decentralization of the look imposed by the maculopathy was higher than is necessary, and therefore, before prescribing the visual aids, was necessary to proceed with a training course on the use of the healthy retina closest to the damaged macula. To achieve this objective, we have developed a software that produces a series of exercises created automatically during the test by the patient himself, and which oblige him to use the best retina portion, creating a sort of a pseudo-macula. Another very important result from these exercises we got has been a significant improvement in contrast sensitivity. A very important step of our research was collaboration in the realization of an intraocular telescope with prismatic effect. As we have discussed before, in cases of maculopathy, it is necessary that the external images reach the retina enlarged. Yet we know that the magnification obtained with telescopic system reduced the view area. So we kept the magnification quite low, adding a prismatic effect by decentralizing the negative lens, then that positive. In this way, the visual acuity is doubled. Thanks to the magnification and the area of vision is reduced only in the small part so as not to impede the normal orientation of the patient. The system works in this way. In a normal eye, the light passes through the lens and reaches the retina to the center to allow viewing of the detail, and the periphery to allow the orientation. When the crystalline deteriorates because cataracts in patients suffering also from macular degeneration, the simple replacement with an artificial crystalline does not allow the recovery of vision, for example, to read. With the implant of the prismatic intraocular telescope in place of a simple artificial crystalline, it is possible to provide a magnification addressing in a healthy area of the retina previously evaluated, creating what we could be called a pseudo-macula. In our website, in collaboration with our supporters, we try to give all the latest information on the treatment of retinitis pigmentosa, macular degeneration, and low vision news in general. Periodically, we organize meetings for patients and/or to their families, and courses for professionals, leading to discussions and debating among the various methodologies. Being careful to support those initiatives that can improve the quality of life of visually impaired patients. In the field of biochemistry, we made a liberal donation in favor of the working group led by Professor Riccardo Guidoni on the development of a molecule for the treatment of retinitis pigmentosa. Latterly, we have donated to the Center of Visual Rehabilitation of the San Paolo Hospital a unit of work devoted exclusively to the assessment of the functional vision of the low vision patients. Vision is the title of the World Congress that the Agency for Prevention of Blindness organizes every 3 years. The next will Vision 2014 in Melbourne, where we hope to bring our contribution and continue towards that goal that all operators involved in take care of the low vision cases are fighting versus the avoidable blindness by 2020. The year that not just coincidentally correspond to the maximum visual acuity for the Americans, 6.6 in UK and Spain, and 10.10 for many other countries. Thank you for your attention.